Again, my career as an interventional cardiologist, I do a lot of coronary artery disease and treating heart attacks. So a good portion of my career is angiograms and angioplasty, where you do an angiogram, you see a blockage, and you potentially fix that blockage with a stent. And then I see those patients and follow up over the course of years. Um, so that's probably the most common. The second most common is probably aortic valve replacements, where before you used to do an aortic valve replacement used to be through what's called a sternotomy, where you'd cut someone's breastbone and the surgeon would fillet out their old aortic valve and sew in a new aortic valve. Now what we do much more commonly is the TAVR procedure, where anesthesia puts someone to sleep, and again that's even that aspect's changing. It used to be in totality general anesthesia, the patient had a breathing tube in, and now they're doing more towards moderate sedation, and less stuff is going on. So in the course of a few years, it's going to be even more simplified, and what they're calling is minimalist TAVR. But so that what we do there is we first we do an angiogram to look at their coronary arteries, then we do a specialized CT scan to measure the aortic valve, look at their femoral arteries, and make sure we can plan out the valve replacement. Once we've planned it out, we bring them to the cath lab, get them sleepy, however anesthesia deems appropriate, poke a hole in typically the right femoral artery, expand that hole, and take a big tube with a squish down valve across their old valve, and expand the valve and crush their old valve and put in a new heart valve. So that's probably and if you're interested, you can Google it, YouTube it. The valve we typically use is the Edwards sapien valve. It's the most common one, but it's a very cool procedure. So that's probably the second most common. Then I do some what we call atrial septal defect and patent foramen ovale. I do some of those closures, and basically, the long and the short is there are two different types of holes in the heart. And again, it used to be something where you'd have to cut the breastbone and go through the rib space, and the surgeon would sew it closed. Now we put a plug in to close that hole in someone's heart, and in certain instances, it reduces the risk of stroke. In certain instances, it reduces the risk of heart failure, just depending on which type of hole it is and what the pressure gradients are. And then another procedure we do, which I do less frequently, but it's becoming more, is if patients have a heart rhythm problem called atrial fibrillation. One of the risks of atrial fibrillation is a stroke risk. And an oversimplified way of thinking of it is a part of their heart called their left atrial appendage collects clots in atrial fibrillation. So a procedure we do is we put a plug in the atrial appendage, and then they can come off blood thinners after a little while. So in older people who have high risk of bleeding, that typically helps them. So those are the big procedures we do.